I knew that I was going to be the last speaker. I didn't realize I was going to be after lunch. And I'm going to talk about measurement. And I'm also following Sean Morrison, who's a very good speaker. And I thought, something's wrong with all of this here. But on the other hand, Sean's talk, I think, really set up the particular question that I've been asked to address. So I don't have any conflict of interest to declare. I am the division chair of palliative medicine at Queen's, and I'm also the senior scientific lead for the person-centered perspective for the Canadian Partnership Against Cancer. And I'd just like to thank Michelle Sims and her team for help with the literature search for looking at this particular topic, and also Courtney Longfield, who's our administrative assistant back at Queen's, for help with preparation of the manuscript. So the question is, does measurement of indicators that address desired outcomes, including patient family reported outcomes and experience, improve the quality of and access to palliative care? It's actually a pretty complex question, and we'll go through that a little bit. When I was looking at it, the different literature, I came across this quote from Abraham Lincoln: "If we could first know where we are and whither we are tending, we could then better judge what to do and how to do it." And I think it's equally relevant today as it was in 1858 when he supposedly said it. The Institute of Medicine, in a document called Crossing the Quality Chasm, said that the aims of our healthcare system are to deliver care that is safe, effective, patient-centered, timely, efficient, and equitable. So these are the aims of the healthcare system in general. And when we're looking at how do we actually measure, how do we look at quality, Donna Bedian's framework is the most widely used, and basically has three different components. If we want to look at quality, we have to look at all three different pieces. So we need to look at structure, process, and outcomes. Structure is which resources are required, what are the settings and qualifications and administrative systems involved in delivering that care. And then what the processes are, how are those resources actually used, and what are the components of the care that's delivered. And then outcomes are, what have we achieved? Is there a change in the health status? Is there a quality of life changed as a result of that particular intervention? And again, the question specifically was talking about outcomes, so it's this latter thing that I'm going to be particularly looking at. So outcome measurement, again, I think is also most important because it's what directly affects the patient and the family. It assesses the effectiveness of the particular interventions, and it encompasses the results of the whole cycle of care. So again, I think this is why we want to look at it particularly. And if we look at outcome measurement in palliative care, I think there are, again, three different main categories of that. One is clinical, the other is audit, and the other is research. So at a clinical level, measurement is used to look at symptom intensity, functional status, and quality of life. It helps to facilitate communication between team members and patients and families. And also it helps to evaluate the effectiveness of the interventions that we actually do for our patients and their families. From an audit, and that's what I think Sean talked about a good deal, and I'm going to come back to that, it has a really very important role in terms of audit. It helps in terms of setting standards for the desired outcomes, monitoring practices, and evaluating performance. And then research, of course, looking at how do you demonstrate results for a particular intervention, drug, or whatever it is that you're going to use. So again, outcome measures in palliative care, three different pieces: clinical, audit, and research. I think then you can look at, again, what are outcome measures? Well, there are really two different levels. One is patient-recorded outcome measures, and they're affectionately known as PROMs, and they're measured often with questionnaires. They look at functional status, quality of life, symptoms, and sometimes satisfaction, although satisfaction is sometimes framed as a patient experience as opposed to patient-reported outcome. And then system-level outcomes, looking at using administrative data, such as to get at outcomes such as where did the individual die, what was the length of stay in the acute care hospital, emergency room visits in the last 2 weeks of life, and other such topics. Then the other term I thought needed to be defined was what's an indicator, because again, that's part of the question. And indicators are used to measure quality of care and services delivered. They're usually very well defined and measure specific aspects of desired outcomes, processes, or structures. So again, you can have indicators that are structure, process, or outcome related. They are usually described with a numerator and a denominator on an aggregated level, and such as a percentage of patients that have done a certain thing or have experienced a certain type of thing. They're effective and quick tools for assessing individual, program, regional, national, and international level system performance. So again, it's something that we can use to make comparisons or audits to help drive quality and improvement at all of those levels, both at an individual, program, regional, national, international level. So quality indicators and measures in palliative care. There are a number of systematic reviews that have been done, and I just wanted to reference one of the most recent was one that Connell did in 2015, and he identified over 284 quality measures. So it's not that we don't have any quality measures in palliative care, there are lots of them out there. And these quality measures were in 13 measure sets, so they were different measures that were in sets so that they had sort of this particular questionnaire measured these certain things. That would be a set. And when they looked at what they were actually measuring, 35% were looking at physical, 23% structure and process, 4% spiritual, and 1% cultural, so clearly underrepresented in those two areas. There also have been numerous international groups who have developed consensus on sets of quality indicators for palliative and end-of-life care assessment. So again, we have a lot of indicators, we have a lot of measures, we also have consensus that's been developed in a number of international groups. Basically, all of these groups took all of the measures that they could find in indicators, and then they used a modified Delphi rating process with usually both professionals as well as patient groups to say what are those indicators that we feel are most important to measure. And then they established consensus on that quality set of indicators for assessment. So again, those are just some of the different groups that have actually come up with a group of performance measures. So this is the question again. So does measurement of indicators that address desired outcomes, including patient and family reported outcomes and experience, improve the quality of and access to palliative care? So what the findings are, so what I thought we should start with, well, what is it that the literature actually says that patients and families value most at end of life? And again, this is a summary of a number of different people's articles and research, but adequate pain and symptom management and psychosocial care was right up there in most of them. Communication of information and clear decision-making, avoidance of aggressive, prolonged dying. Treatment choices are followed, so if you've made a choice that the health professionals actually have done what you've asked them to do. Creating a sense of completion and preparing for death. Contributing to others, strengthening relationships, a sense of control, affirmation of the whole person, and dying at home. So these are all things that, again, patients and families said that they valued most as they approached their end of life. So what is the evidence, which is the question, what is the evidence that actually measuring patient-recorded outcomes actually makes any difference? And so again, there were a number of systematic reviews that have been done, and I've just summarized these. But basically, there was strong to very strong evidence that it improves patient-clinician communication. It increased the identification of unrecognized symptoms. It increased monitoring of symptoms. Also, when they were looking at quality of life data, that if the quality of life data was collected, there were actually a larger number of actions taken that actually addressed quality of life. They improved patient satisfaction and experience, and there were higher symptom scores had higher rates of clinical action. So that in one study, I believe it was Sensao, who was here yesterday, basically showed that if the scores were high, then when they looked at what was documented in terms of what clinicians had done, there were higher levels of them actually doing something if there was evidence that they'd actually had their symptom scores measured as opposed to not, and that there were less debilitating symptoms at the next visit. So again, they're not direct things, but they're indirectly showing that, in fact, that some measurement of the intensity of the symptoms and these other issues actually do have some benefit in terms of patient outcomes themselves. There was moderate evidence in one systematic review of improvement in psychological and emotional factors. And this particular review didn't find an improvement in symptom burden and quality of life, which was somewhat surprising. And then another one showed, again, that there was effectiveness of interventions that were focused on quality of life. So again, generally speaking, some moderate evidence, but some very strong evidence that, in fact, collecting patient-reported outcome measures actually does improve those things that patients and families value. This was a study that was done by Connell and his colleagues, and they wanted to look at which components of palliative care must be delivered consistently to achieve improved outcomes. They wanted to look at the relationship between conformance with 18 palliative care quality measures, so things that they were measuring as a group, and individuals' quality of life. So was there any evidence that if people actually did the measurement, conform to what these outcomes, these quality measures were, actually made any difference in terms of how patients were at the end of the day. And this was done in 4 organizations in North Carolina who were part of a palliative care collaborative. So again, this was volunteer. These people agreed to come together to start measuring similar patient-reported assessments. And they were patient-reported, and the provider actually did the entry of these quality-based needs. And what they found was that significant predictors of high quality of life were related to the individual's functional status, as well as basically their prognosis, which is what you'd kind of expect. But they also found that if people were measuring emotional well-being and were measuring comprehensive screening, doing comprehensive screening assessments, that they had a higher quality of life. So again, it's not a cause and effect, it's an association. It's indirectly suggesting that if you actually measure these things, that they're going to have an impact on the individual's quality of life. But we have to start asking people in a consistent type of way. So what's the impact of PROMs on quality improvement? Because again, the idea is that if we're collecting this information, that it's one of the things that is going to help to drive quality improvement. And this was a study done by Abernathy and group. And basically, they have an electronic PROMs database. So they collect this information routinely on individuals that are coming, and I believe it is to a cancer center particularly. And what they had done was they were collecting this information, and they found that patients with gastrointestinal and breast cancer had significant sexual distress. And so as a result of actually collecting this information, they developed an intervention. They used something for the women with metastatic breast cancer called the Pathfinders program, which was specifically designed to relieve psychological distress. And it showed at the end of the program, that there was a very positive effect on distress and despair. And also as a result of actually collecting this information routinely on individuals, they developed a psychosocial care triage algorithm, so that again, collecting the data helped to drive quality improvement, both in terms of developing a new program as well as an algorithm to use if individuals were not doing well and scoring high in certain areas. So again, a good reason to do these. Sean Morrison, he talked a bit about Australia, and that was great because I think that we have a lot to learn from them. And they, it started as a part of their nationally funded program, the Palliative Care Outcomes Collaborative. And this was designed to improve palliative care through an audit and feedback quality cycle. So basically, the individuals who are part of this collaborative, so these are palliative care services or programs scattered throughout Australia who voluntarily joined this collaborative. So it wasn't something that was imposed on them. And the whole point of it was to help services measure the quality of their symptom control. So the services agreed to use common patient outcome measures at the point of care. So again, patients and families were entering the data at the point of care. So that because they were getting it sort of at the point of care, that was rolled up because everybody was collecting it in the same manner to a national service level performance data so that they had common outcome measures where they could do some comparisons across the different sites. And they were able to set national benchmark standards for comparison. They also, as a part of this program, which I think was probably critical as well, is that the federal government nationally funded people to work with the individual palliative care programs or services to implement quality improvement initiatives, to use the data that they were actually collecting in a way to drive quality improvement. The data was aggregated and analyzed, and it's reported back to the services every 6 months. So again, something that Dr. Morrison was talking about, and the fact that the audit, frequent feedback, that's what helps to drive improvement, and I think, again, one of the critical things that are necessary in order to make real value of this information. So this is a study that was published in last year by David Currow, looking at the data that they had from 2009 to December 2011 for the Palliative Care Outcome Collaborative. They looked at 8 routine measures, including physical, psychological, and family caregiver domains, to see if there had been any improvement over that period of time through this process that they had. And what they found was that there were statistically significant improvements in all domains, both of patient and clinician-reported outcomes, except for pain. Now, it's kind of interesting as to why pain wasn't better, but maybe they were doing a good job in the beginning. I just don't know. But again, all of the domains, there was significant improvement, again suggesting that this is a very good and useful way of trying to drive improvement across the whole system of care. So what about Canada? Where are we in all of this data collection around palliative care? Well, in 1995, the Special Senate Committee on Euthanasia and Assisted Suicide reported scarce, accurate data on the number of programs, the number of institutions and patients. There was no data on comparative costs, and there was little on other aspects of palliative care. Unfortunately, I'm not sure we're a great deal further ahead, but we'll show you some of the things that have been done in the interim. In 1996, a study funded by Health Canada and then projects in 2009 funded by the Canadian Partnership Against Cancer, they looked at program-level data to address structure and process questions. And what they found was that there were a variety of formats, software and coding structures, so that nobody was collecting, or very few people were collecting data in the same way or were collecting the same data. That there was variable completeness and accuracy and consistency in what was actually being collected, and that few collected the data electronically with using ESOS or PPS, which is a functional status measure, and none collected quality of life for patients or families, or patient or family satisfaction data. And again, I'm not sure that we're a great deal farther forward today than we were back in 2009. Looking at administrative data, there has been some work that's been done, some published articles. Again, there's some service utilization patterns within provinces. So some in Ontario and Quebec looked at just what's happening within those provinces. There's also been an association between home care, palliative care services, and end-of-life care indicators and costs. Again, those are done in Ontario and Quebec. And there have been comparisons of health service quality indicators between 3 provinces, by Xian Zhao, and 4 provinces in an article by Barbera and colleagues. So again, there's some work being done, but it's very little work in many ways. The Canadian Institute for Health Information, CIHI, in 2013 reported on the use of hospital services in the last month of life by cancer patients who died in acute care hospitals. So again, another piece of work that had been done. This is on a yearly basis, the Canadian Partnership Against Cancer produces a cancer system performance report. And since the first mandate of CPAC, they had started to institute trying to have distress screening rolled out across Canada. And this distress screening included the Edmonton Symptom Assessment System. And this is the most recent report from 2015 or 16, actually, sorry. And basically looking at how many provinces have actually, again, in the cancer system, started to collect ESOS data routinely. And you can see that, if you can, in the first column, that basically there are 7 out of the 10 provinces that are collecting it in a provincial kind of way. 2 different provinces are partially collecting this information. 1 province hasn't started yet. But this is actually an improvement because in 2007, only 2 of the provinces were collecting ESOS data. So there has been evidence of improvement. And again, there is ESOS data being collected routinely in cancer system. It's just that it isn't necessarily routinely collected in the palliative care broader community. And again, I think this is something that we could build from. This is, again, a part of the report looking at hospital deaths, which are in purple. The green is the private home, and the blue is other. And it looks at what are the percentages of people dying in these different places in the different provinces across Canada. And you can see that there are there's fairly big difference between some of the provinces in terms of place of death, in terms of hospital, and again, the highest one is Manitoba. But one of the issues is that, in fact, St. Boniface Hospital is an acute care hospital, and they have a palliative care unit there. And so, again, the numbers are higher because of that. And in Quebec, when they're looking at hospital deaths, they also include long-term care facilities. So there's no standardization of how these are actually collected. And so when we look at these, we have to do some interpretation as well because, again, we're not collecting data in the same way. But it is something that can drive improvements as we see when one province is doing better than another, then what are the things that we can do to emulate that particular province. Another thing that I think is important in terms of Canadian context is that Accreditation Canada actually has developed standards for hospice and palliative and end-of-life care. And in those standards, the standards 7.5 and 7.6, it says that the team conducts an initial assessment and routinely thereafter recommending that the organization administer ESOS. So that the standard is that ESOS is getting collected routinely. And that in 7.6 that they assess the client's symptoms regularly in a standardized process using valid assessment tools. So again, I think that this is something that we potentially could exploit. This is a standard that people are supposedly following, and again, can we actually start to capture this information in a way that will help to drive improvements across the system? The Ipsos poll said that the majority of Canadians think that family members, caregivers, and patients should be surveyed to evaluate treatment effectiveness as well. So there, I think, support for that from the Canadian context. We know that most of the provinces and territories are developing palliative care indicators to help monitor service delivery. And currently, unfortunately, there's no coordinated effort to collect common data elements at a palliative care program level. So the implications of all of this, I think, are that Canada does have the building blocks to develop a robust system for measuring outcomes in palliative and end-of-life care. Again, I think I've shown some of those examples. the Canadian Partnerships Initiative Against Cancer's initiative to increase standardized screening for distress for cancer patients could be expanded to include non-cancer patients as well. And then I think that Australia's national initiative really is an excellent model for us to explore, and one that I would certainly highly recommend. So thank you.
Thank you very much, Dr. Dudgeon. Don, over to you.
Okay, thank you very much, Fred. The first question on this section goes to Mark Jerry. Mark.
Dr. Dudgeon, thank you for your presentation and thoughtful work. You referenced Connell's 2015 review about the quality indicators. And of the 284, I was very interested that they showed a very low percentage for those spiritual and cultural indicators. And while we've seen some success in data collection that improves quality of care, such as the triage algorithm, there still seems to be a lack of consistent quality care data for palliative care that is non-biomedical. And so I'm wondering if perhaps you could say a little bit more about what kinds of approaches you might suggest to better capture some of that non-biomedical indicators for quality of care in palliative care.
Well, I think that one of the issues is, do we have the instruments to actually measure those? And that's one of the biggest problems right now. Reference was made earlier today to the issue of compassion and the work that Shane Sinclair is doing. And again, I think similar kind of work is required in terms of how do you actually measure improvement in terms of spiritual, and how do you look at cultural issues as well. Palliative care is one of those areas where there's a tremendous amount that's not known, and again, I'd say yes, there is more in the symptom in this biomedical part, but there's huge gaps there, but bigger gaps in the emotional, psychosocial kinds of issues. So I think it's a question that we need to do more research and work to try and build that area, because it's very important.
Thank you.
Okay.
Ken McDonald, your question.
Sure. Thanks again. I've got so many questions, but I'll just ask a couple, and hopefully the audience will pick up on some of this. I'm intrigued by the way in which data is actually used. Often we make an assumption that simply because we have the quantitatively right data that we will make the qualitatively right decision. And I think if anybody's worked within an organization, they know that's a bit of a ruse, and that there are all kinds of ways in which rationalism just doesn't work within an organizational context. And, partially that, I think, is getting at what Mark is getting at. I know students, graduate students who've tried to do, and have in fact done, good ethnographic work within cancer wards. But the difficulty that it took them to get permission to actually do the work because of the lack of familiarity with methodological practice was striking. And the degree to which people did not seem to see the utility of the potential results that would come from that kind of work was also striking. But I think we're at a moment now where there's an opportunity to develop a new institutional context and make recommendations about exactly the kind of thing that we're talking about. How do we implement a better system of data collection that allows national comparisons to be done while simultaneously addressing the diverse experiences that people have as they go through palliative care? And this is going to be probably an extraordinarily tough, if not impossible, question to answer. But what recommendations might you give if I were to ask you, how would we put forward advice on the need for a pluralist methodological approach within a new institutional context for data collection?
Well, I guess I start with low-hanging fruit, but that's the stuff that we're doing now and expanding it to other areas. I think that I didn't talk about, I talked about outcomes, I didn't talk about patient experience, and I think that the patient experience literature actually uses more of the the qualitative kinds of input than the outcomes literature at the moment. So again, it would be, I think, trying to build that in. I think certainly in the reporting that we are doing at CPAC and other places is trying to build the story around the data as well to give it a more wholesome value than it is just to have the numbers and show what the numbers show, basically. So, I mean, I guess looking at CIHR and other institutes saying that this is an area that needs further development and potentially looking at putting more resources to that type of research. I think there's a growing appreciation of that, of the qualitative component of research over the years. I think those of us who are physicians didn't used to know much about it, and Sean's shaking his head as well positively, that I think we've come to appreciate the value of that more, and so I think that helps as well. I'm not sure I've answered your question, but those are sort of the thoughts that come to mind.
Well, certainly partially, even something as useful as knowing that CIHR is putting out calls for this kind of work, or it's on their horizon and on their radar.
I'm saying they should. I'm not sure that they are. But I mean, the good news is that Shane's work in compassion was one of the few palliative care studies that actually was funded. So somebody's listening.
Right. That's a follow-up question. What room or capacity is there within a PROM approach to actually employ diverse methodological design, or is it solely questionnaire-based? And I ask the question partially out of a suspicion that questionnaires are not, in fact, the best way to get useful information out of people at different stages in palliative care, especially people who are not sort of perhaps culturally familiar with the data collection instrument itself.
Mm-hmm. I think it's a primary way. I mean, there are studies where they've done other things, but again, on a continuous type of basis, I'm not sure. Again, I go into more the experience literature rather than the sort of what I would consider PROMs proper, but I don't know if some of my other colleagues have are familiar with that, so that I see them as sort of somewhat they have been somewhat separate. I mean, but I think we probably, and we should be collecting both PROMs as well as patient experience, and then there would be that marrying of both, I think, both qualitative and quantitative.
Thanks.
But I don't know, Sean, if you have anything or, no? Okay, thanks.
Dr. Dudgeon, you've clearly, you're doing a great job in engaging us at a really tough time in the day, so thank you for that. And I do have a question for you, actually a two-part question. Do you think that there's anything that we should be considering in a national strategy that will encourage more qualitative research around the patient experience and patient and family satisfaction data? And coupled along with that, I'm just wondering, is there a special role for academic research and teaching hospitals that they can play in any of this?
So, I mean, answering the second one would be yes. I mean, certainly, again, trying to get the academic centers, basically getting the academics to start paying attention to these kind of questions. I think that's part of the issue is, you know, what is it that's getting funded? I mean, because that is often what people will do, but I think also that raising the profile of the importance of patient experience, and so that's something that people start to work on. So I'm not sure I quite got your first question, Carrie, I'm sorry.
That's fine. I'm just wondering if there's, within the context of a national strategy, is there anything that we should be considering that would help promote increased uptake of qualitative research around the patient satisfaction and patient and family experience?
I mean, I don't know, other than potentially recommending that, you know, that it become a routine part of practice. I mean, I think that we need both the quantitative, because we don't have quantitative, nor do we have qualitative. I think we need both. I don't think it's an either or, and that the recommendation would be that both should be something that is routinely put into practice. I think that, again, that potentially one of the ways would be through Accreditation Canada, that again, that satisfaction surveys and more than that are a part of what's required of palliative end-of-life care programs. I think that's one way you could influence it to make it something that more people would be doing, and that somehow that gets reported, because that's the problem right now. with Accreditation Canada, they're doing this, but it's not getting reported anywhere. We don't know, we can't do the comparisons, and I do think that comparisons help to drive improvement. So that audit that Dr. Morrison was talking about is so critical to drive improvement, I think. So again, collecting it and making it visible in reports that we can then learn from each other.
Wonderful, thank you.
Other jury questions? Sabine?
Thank you very much. That was an interesting presentation. I guess my comment would be around the impact, and just to kind of pull this down from what you're showing us, is that high need for praxis with research and delivery. And I'm just curious, as we see our interdisciplinary approach to palliative care, hopefully within a national strategy, improve, that we see stronger voices in some of the psychosocial aspects of our care across the country. Do you think that will help make room for more opportunity for research in this area?
I think if we're routinely collecting data about patients' intensity of symptoms and psychosocial issues, et cetera, that data drives not only clinical practice, so that, I mean, if you're aware of something, you can respond to it. If you don't know about it, it doesn't happen. You don't, and you can't respond to it. And if you're collecting that data regularly, you can then use it. I mean, that's again what Dr. Morrison was talking about. If the data is there, it helps you in terms of doing research with it as well. So it's got importance both from the individual patient perspective, but it also importance for research and also importance in terms of that quality improvement component. So I think it's really quite critical. I was part of the group of a team at Cancer Care Ontario when we introduced Edmonton Symptom Assessment System across the province. And I mean, in Kingston, we had one of the patient families came up to me and said, "Thank you for doing this, because we didn't know that our family member was depressed or was anxious," and they put that on the comment. So that again, it can, even for families, it can raise that to which they didn't know. So as health professionals, we're even less likely to know. So I think making things visible is what's important, and then you can respond to them and learn how to respond to them better.
Yes. Just shows the responsibility, I guess, we all have to improve this in the leadership model. So thank you.
Other questions? Going once, going twice. This is the last chance to ask questions. Thank you, Fred. Thank you, Doctor.
Okay.
Thank you very much, Don. So ladies and gentlemen, we have some time for questions from the room and from our audience online as well. Please approach a microphone if you have a question. It is that time of the day, isn't it?
Thanks very much for your presentation. I really appreciated that you oriented it around a quality improvement cycle to bring in the reality that it isn't just measures, it's also what you do with them. I just want to make sure that I'm understanding, though, when you differentiate outcomes as quantitative, and did I understand you that emotional and spiritual state of health is patient experience?
No.
Okay.
No, if that sounded like I said it, I wasn't.
Okay.
I didn't mean to.
Okay.
No, they're also patient-reported outcomes as well. So yes, no, I think sorry.
Oh, no problem at all. And has anybody played with the idea of using power distribution rather than statistical norm distribution to represent data as a way to getting at, because it seems to me that part of the issue here is that palliative and family health is such a idiosyncratic, like a very customized kind of approach, that understanding really what the distribution is rather than forcing it into a norm would be useful. Has anybody played with that to see if it helped?
I look at my colleagues over here, I'm not aware of it, but no, I think the answer is no.
And then my third one, has anybody done any surveys or assessment of caregivers, not just family, but professional caregivers, emotional and spiritual state as well? Because I mean, it strikes me it's very high relational services we're dealing with here, and so the the level of well-being of the professionals is as important as everybody else. So is anybody doing that in the human resource development world?
So I'd say there's a little bit of work being done about caregivers who are not professional caregivers. There's even less being done about professional caregivers. But there is some work that's been done, but I wouldn't say it's not very much.
Okay, thank you.
Thank you.
Hi, Deb. Thank you very much for that rundown on all of the quality metrics. And I wanted to ask, I don't mean to sound, I love the qualitative and the patient perspective, and I don't want to sound like I'm trying to turn the camera away from that. It does strike me that a lot of what the sort of decision makers seem to be more focused on are the cold hard cash, wait times, other type of metrics which are, again, maybe poor surrogates of quality, but nonetheless what they look at. It does strike me sometimes that what palliative care is actually very good at moving from the studies is actually some of these colder, harder metrics, costs of care, waiting times, ALC numbers, et cetera. I would be interested to hear you talk, if you can, a little bit about sort of meso and macro level metrics that we could maybe be looking at that are surrogates of quality. You talked about location of death, but maybe rather than looking at it at a smaller institutional level, more at a regional level, more at a overall cost of care, things at a regional level. Part of the problem in this in any discussion of quality, I find, is that it becomes very easy to dump your problems into somebody else's pile. By you cut your services to save your budget, it ends up as a line item in someone else's budget. So your budget looks great, but overall everyone's lost. I'm not sure if I've fully formed that as a question well, but I would be interested to hear your thoughts on, how we look at this, the unit of analysis of metrics and balances of metrics, and how we can start to leverage metrics that a lot of stakeholders find important, like costs of care, et cetera, in how we assess quality, because palliative care does seem to be pretty good at moving those.
Well, I mean, we need to use administrative level data to answer some of the questions that you're talking about. And I think, you can look at, you can look at it at all the different levels. So at a program level, at a regional level, at a provincial level, and at a national level. What they're doing in Australia is taking a program level approach to try and drive improvement at that level. And they're using patient-reported outcome level data, so that they're using questionnaires and things that people answer to help improve other kinds of outcomes that are maybe measured in the administrative data as well as in the patient-reported outcome data too. So I think it's a combination of those. My sense is that when I was at CCO, when you're collecting something, you want to make it simple because everybody's really busy. You want to make it worthwhile, that it's actually got a reason for them to be collecting it for themselves, because if it's only the administrator up there that wants it, that's less likely to be done. And you want to, make it worthwhile in terms of the outcome for the patients. I mean, so those are things. So again, I think patient-reported data is really important. I think it can help to drive, but you can. My goal is to try and bring it up to the national level, that we can then start looking at outcomes. And the outcomes isn't right now. We're collecting how many people are actually collecting the information. But that's only because we have to get them to collect it before we can actually use it to look at real outcomes. Because the outcome is, in 24 hours, how many patients who had a severe score now have a score that's mild. Those are the kinds of outcomes I think that we want to get to eventually, but we have to get people collecting the information in a way that we can do those comparisons. So again, I think that the beauty of what they've done in Australia is that they've collecting it at a service level, they're rolling it up to region, and they're rolling it up to the national level, and then that helps to drive performance at all levels, and that's, I think, what we should be doing as well.